Welcome to this module from the Hip Hope Network, where we will review the key principles of radiographic assessment of the hips in children with cerebral palsy. This video is intended as an educational resource for medical professionals managing children with CP. Of all children with CP, more than one-third will develop significant hip displacement as they grow. With early detection of hip displacement, treatment can be initiated to keep the hips in joint, helping to preserve function, prevent pain, and potentially prevent secondary spinal deformity. To facilitate early detection, CP hip surveillance guidelines are available. This region-specific guideline from British Columbia, Canada, illustrates that in the guidelines, frequency of monitoring beginning at 2 years of age depends on the patient's gross motor function classification system level and includes both serial physical examination and serial X-rays. Further details and recent modifications to the care pathway for CP hip can be found on the website for the American Academy for Cerebral Palsy and Developmental Medicine. Imaging of the hips should also be ordered if clinical examination shows any signs of concern or deterioration. Further details regarding clinical examination can be found in our module on hip assessment in children with CP. For imaging of the hips, an AP pelvis X-ray should be ordered, specifying the purpose is for CP hip surveillance. Using the traditional technique for acquiring the AP pelvis X-ray for CP hip surveillance, where possible, the pelvis is in the horizontal position and the lower limbs are in the neutral position, with the patellae pointing directly forwards. In children with hip flexion contractures, the lower limb position should be modified to allow flexion of the hips so that a proper AP pelvis X-ray can be obtained. Both hips should be visible on the film, including the proximal femurs to below the lesser trochanters. Ideally, the entire bony pelvis should be visible, and if gonadal shielding is used as per institutional guidelines, it should not obscure any part of the acetabulum. Hip displacement in cerebral palsy is quantified using Reimer's migration percentage, which measures the amount of femoral head with no coverage from the bony acetabulum. To determine the migration percentage on the AP pelvis radiograph, draw Hilgen-Reiner's line, which is the horizontal of the pelvis connecting the triradiate cartilage of both acetabuli. In cases where the triradiate cartilage is no longer visible, a line connecting the most inferior aspect of the ischial tuberosities can be used instead. Next, Perkins' line is drawn perpendicular to Hilgen-Reiner's, in line with the lateral corner of the acetabulum. Finally, lines parallel to Perkins' line are drawn, marking the lateral and medial borders of the ossified femoral head. With these markings in place, the width of the head lateral to Perkins' line is measured, as is the overall width of the ossified femoral head. Migration percentage is then calculated from these two numbers. While migration percentage in a normal hip is typically less than 10%, a migration percentage of less than 30 has a low risk of progression to hip dislocation. A migration percentage of 30 to 45 represents a subluxated hip and a moderate risk for progression to hip dislocation, while a migration percentage of greater than 45 is a very subluxated hip with high risk of dislocation, or the hip may be dislocated already. Due to measurement variability for migration percentage, it is important to monitor for changes over time, particularly in borderline cases. The utility of the migration percentage is further illustrated in this example. On initial observation, the patient's right hip appears significantly displaced, but the left does not look that bad. When migration percentage is measured, though, it indicates that there is a high risk for progression of displacement on the right as expected, but there's also a moderate risk the left hip will continue to displace. Migration percentage measurements can be made manually or with the assistance of the Hip Screen app, developed by Shriners Hospitals and currently available to users at no cost. When both hips have a migration percentage less than 30 and the patient is otherwise doing well, continue to monitor as per hip surveillance guidelines. When either hip has a migration percentage equal to or greater than 30, or the patient has pain, a referral should be made to a pediatric orthopedic surgeon for assessment and discussion of potential management options. Pelvic obliquity is an important factor to take note of on the radiographs if present. Hilgen-Reiner's line is drawn, as is the horizontal of the radiograph. The angle between these two lines is then measured and provides a means to quantify severity of pelvic obliquity. In the absence of pelvic obliquity, this angle should be less than 2 degrees. Pelvic obliquity, noted either clinically or radiographically, especially when it is progressive between examinations, is associated with an increased risk of progressive hip displacement. As part of the assessment of children with cerebral palsy, orthopedic surgeons consider some additional radiographic parameters. Before we proceed to describing significant pathologic findings, let's review radiographic findings you will see in healthy hips in children with CP. This is an example of a 6-year-old boy with right-sided hemiplegia and a GMFCS level of 1, which is associated with a very low incidence of hip displacement. There is no significant pelvic obliquity. The acetabular roof bilaterally is well developed with a normal contour and a distinct and sharp lateral corner. The medial joint space is not widened, and the joint space is even around the head, indicating concentric reduction. Shenton's line is intact, also indicating the hip is sitting in good position. When migration percentage is assessed, it is confirmed that much less than 30% of the head is uncovered laterally. Virtually the only finding on this radiograph to suggest this patient has CP is the appearance of mild valgus, as measured by the head shaft angle. However, in this patient, this may actually be projectional artifact, due to the fact that there is femoral anteversion and the hips have been slightly externally rotated, as suggested by the more prominent lesser trochanters and the appearance of the greater trochanters, particularly on the patient's left side. As mentioned, the head shaft angle is used to measure coxa valga and CP. This measurement is made by drawing a line perpendicular to the epiphysis and another in line with the femoral shaft. The angle subtending these two lines is the head shaft angle. The normal head shaft angle is between 125 and 135 degrees. This is a film from a 6-year-old girl with asymmetric bilateral CP. Although neither hip is normal, for illustrative purposes, let's concentrate on her left hip, which is obviously her worst side. In addition to coxa valga, the proximal femoral epiphysis shows asymmetry with diminished growth and ossification on its medial aspect. This radiograph also illustrates hip subluxation with a wide medial joint space and disruption of Shenton's line. On the acetabular side, the teardrop, which represents the medial wall of the acetabulum, is wider on the left side due to altered acetabular growth from chronic hip subluxation. The slope of the acetabulum, as measured by the acetabular index, is high, indicating dysplasia. The contour of the acetabulum is abnormal, with the presence of a Gothic arch. The Gothic arch represents erosion of the superolateral margin of the acetabulum. The presence of a Gothic arch on radiographs is important because it is associated with an underestimation of the migration percentage. All of these factors, considering both the acetabular and femoral sides, considering both hips, and additional clinical factors, will contribute to the surgeon's decision regarding what surgery a patient will likely benefit from the most. But no such treatment can happen without timely recognition and referral to them. Working together, we can help ensure children with cerebral palsy are able to function comfortably at their maximum potential. Further educational materials on this and related subjects can be found on the Hip Hope Network's website. Please note that the material presented in this video is strictly for educational purposes and is not intended as medical advice to patients or their families and should not be used as a substitute to proper medical assessment. Thank you.